Hi, welcome. I'm Dr. Lewis Hassel, Professor of Pathology at the University of Oklahoma Health Sciences Center, and I'm pleased to share with you a really fun and sometimes challenging case that I thought might be of use to you. Our program is part of the Digital Anatomic Pathology Academy, and that is a joint venture with Path Presenter and the Digital Pathology Association. So our case today is a quick look at an endometrial biopsy in a 50-year-old woman with abnormal bleeding and an abnormal pap test. I think because of the abnormal pap test, their initial impression was that this might be a cervical cancer or cervical lesion, and so they sent us what was termed a cervical biopsy, probably a curettage. So, as we look at this, we see a very complex glandular proliferation with a lot of very simple glands, elongated, almost papillary structures, as you see here. And I think you can appreciate at low magnification, there's a bit of hyperchromasia as well, but no real solid growth, a little bit of maybe polypoid, almost villiform in areas. And looking at the cells, we see there's very little stroma, and the cells have a nice tall columnar appearance, fairly well differentiated in most areas, but a few areas more high-grade appearing nuclei. So if we're thinking this is an adenocarcinoma and in the cervix, we'd usually think first of a endocervical type adenocarcinoma. We look for apical mitoses, and sure enough, there are a few here. So right off the bat, my thinking was, oh, this could be a very villiform type of endocervical adenocarcinoma. But because there was so much of it, it was very tall, columnar type of things. I wondered about the possibility of an endometrioid carcinoma and felt like we should exclude that. So we did a couple of stains initially to evaluate for that possibility, and those would include Vimentin, CEA, P16, and PAX8. So here is the PAX8 stain. As you can see, it's diffuse and strongly positive. And while there are some endocervical carcinomas that can be PAX8 positive, it's by far more frequently encountered in endometrial type tumors. Uh, Here is, let's check what our um, control tissue is here. Oh, excuse me, this is not what I want to show right now. Because of the possibility of endometrial carcinoma, I did immediate MMR testing, and that was all intact as well. Here, however, is the estrogen receptor stain. And as you can see here, this is dead negative. There is virtually no positivity, and anything that looks like staining is just artifact. That would be unusual if this is an endometrioid tumor. Looking a little further, here is the CEA staining, which we would expect to be positive if it were endocervical. So let's look at the P16 here. Excuse me. No, that's not the P16. That's not the P16. That's SNAPsin A. Here's our P53 stain. Again, something we do routinely if we think it could be endometrioid. And this is a little bit more intense staining than usually encountered, but it's not truly a mutated pattern. Notice we have some cells that are fairly positive, strongly positive, but then we have a lot of intervening weak cells. So this is not the usual wild type pattern, but it is a wild type pattern. It's not diffusely overexpressed, where here would be our control tissue, expecting everything to be positive. Here is our P16 staining, and as you can see, we have this sort of mosaic modeled pattern, some positive cells, some even blocky positive areas like this, but on the whole, a mixed pattern. So this, again, tends to exclude an HPV-related endocervical carcinoma. So I'm going to go back and think about this lesion. Since this is not an endocervical tumor, it's not staining with our markers that we would expect with endocervix, but while it does have PAX8 positivity, it's hormone marker negative. So that made me a little suspect. This, if it were an endometrial tumor, should be a low-grade, well-differentiated tumor because it's all glandular, no solid growth, and that's not what we're seeing here. So I wondered, could this be an atypical or an unusual variant of endometrial adenocarcinoma? Specifically, could it be a mesonephric type tumor? So we did the excuse me, there's not it again. We did the GATA3 stain and TTF1 stain. And sure enough, here is the GATA3 stain, which, as you see, marks every nucleus. So this is pretty strong evidence, coupled with the negative hormone markers, the intact mismatch repair proteins, and the negative P53 stain, excuse me, the wild type P53 stain that's a little abnormal, all fit together with mesonephric type adenocarcinoma. So we'll share again our PowerPoint slides here and just talk a little bit about the type of carcinoma that we could be looking at and the clues that might lead us to suspect a non-endometrioid cancer in a sample like this. So, of course, first off, the most frequently encountered non-endometrioid tumor would be serous carcinoma, anything with a mutated P53 stain. The next most likely thing might be something with a mixture of clear cell carcinoma or something like that. So looking for clear cell changes is also important. And that would also, either of these would also be associated with a loss of hormone markers. So that's a good reason to be doing hormone markers fairly routinely because it can help you to avoid this pitfall. Of course, the other atypical variants are undifferentiated or dedifferentiated carcinoma. So extensive solid architecture with high-grade nuclei should also clue you in. And then small to intermediate-sized glands only. Many of these mesonephric tumors tend to have fairly uniform, small to intermediate-sized glands. This particular case did not really have that pattern because it was more a villiform or a large glandular pattern. And then lastly, anytime there's a big discrepancy between your nuclear grade, a very high NC ratio, in an otherwise grade 1 pattern, I think should trigger some additional thinking on this type of a lesion. So Mesonephric-like carcinoma is a rare subtype, although we are seeing it with increasing frequency as we become more adept at recognizing it. And it's important to recognize because it does have a higher risk of recurrence and an increased tendency to metastasize. The morphologic hallmark is this combination of architectural patterns with a tumor without squamous or mucinous differentiation, sort of intermediate-sized glands, and occasional intraluminal dense secretions as can be seen. That's more in the cervical or in the adnexal tumors. We haven't seen that quite the same amount in the uterine Mesonephric-like tumors. But the real key here is the low-grade morphology architecturally with negative hormone markers should prompt you to think about additional staining. And that should include PAX8, GATA3, TTF1. Those are the things that are going to help you identify this and pick it out of the background. Usually these tumors are mismatch repair proficient and P53 wild type, though as our case indicates, they may have an altered P53 morphology. And in the background, KRAS mutation is often present. So our final diagnosis on this case was endometrial, not endometrioid, adenocarcinoma, most consistent with Mesonephric-like adenocarcinoma. Well, I hope that you've enjoyed this and found it useful, and that it will help you in future cases that you encounter. So thanks so much for joining me, and until next time, may all your diagnoses be astute, accurate, and well supported.